on drugs yourself based on your income. It's not, there's no set kind of amount, but it's kind of a sliding kind of scale, as I understand it. And then at that point, you can actually take advantage of the program. So there are more families. There are 18,094 families enrolled and 32,173 individuals enrolled. But as the member can see from the prior figures that I've provided, many of those folks aren't actively participating. They haven't been able, for whatever reason. I really don't know if it's because their drug needs aren't great enough or because they, you know, they've decided not to pursue the program or whatever, but those are the numbers. Yep.
The Honourable Leader of the Progressive Conservative Party.
Thank you, Mr. Chair. It's my understanding from that program that it was designed for families who had no drug program, no drug coverage, and then it was also designed for people who experienced unusual financial burden at certain times, and maybe not all of the time would they have to be recipients of this. Are you able to tell us how many of those families that you've identified as being enrolled are people who had no program, no drug plan, and how many are people who have taken advantage of it when the financial burden was too great for them to bear?
The Honourable Minister of Health.
Thank you very much. And I would say to the Honourable Member, through you, Mr. Chair, that based on the information I have, I can't really answer that question at this stage, but I will again undertake to see if we have that information in the department, and if so, we'll provide it to the Honourable Member. You know, this, I think, begs that we all know, everybody who's a member here, particularly people who've been here for a while, we all know of the challenges that families have around getting access quite often to prescription drugs, particularly if they are people who have low and modest incomes and work in an environment where there is no drug plan as part of their employment. And we all know as well that the costs of prescription drugs have escalated considerably, particularly as you see more and more new drugs come on the market. And I think that every member of this assembly recognizes the limitations of the pharmacare programs in the Atlantic region. I think that you know, from time to time we'll see accounts in the newspaper, Mr. Chair, that talk about the accessibility of pharmaceutical health care across the country, and we will see that other provinces have very, very robust pharmacare plans for their citizens. But Atlantic Canada has lagged considerably behind the rest of the country in the provision of any kind of plan for their citizens. And this plan, this attempt to make a prescription drug program available to families and individuals is, I think, an important one. But we can see from the numbers that there are still people out there who probably don't have access because of the limitations. And we all recognize that the limitations in our plans are often due to our financial capacity to provide more robust plans for people. But I think that one of the things that I feel fairly strongly about, Mr. Chair, is that we have now in our province, we have a number of drug plans. We have a pharmacare plan for people who are in receipt of social assistance. We have programs for diabetics, the diabetic program. We talked earlier about the exceptional drug programs, MS and Fabry's and some other drug plans. And then we have the family plan. It would be, I think, desirable to be able to look at whether or not there is any benefit to, I wouldn't say amalgamating plans, but a greater degree of harmonization, coordination, a central administration, whatever, to see if we could realize some efficiencies and then reinvest any savings that you could realize from having, all of these different plans, reinvest them into providing better coverage for people in the province, so that we would actually see more people having access to the prescription drugs they need. And this is something in the coming year I would certainly look to the folks in the department to consider and do some work on. Thank you.
The Honourable Leader of the Progressive Conservative Party.
Thank you very much, and I know that the clock is ticking on us here, but I do want to suggest to the Minister that I think it's important to keep that program in your sights. We recognize that there has not been the uptake that was initially projected, and there may be a number of reasons why. Sometimes it's communication, sometimes people aren't aware of it, but I thank you for keeping it in the budget at this point in time.
Thank you. The time is allotted for the Honourable Member. Now I will recognize the Honourable Member from Dartmouth East.
Thank you, Mr. Chair, and I'll share my time with the member from Clayton Park.
Very kind of you.
Thank you. Mr. Chair, the question, my first question for the Minister, I'm not sure if she's aware some of the issues, particularly around the Dartmouth General Hospital, and specifically of late around blood collection services, which are backing up into the emergency room as people try and make use of those. Well, frankly, get blood collected, which is forcing people to move to private service providers to get that done. And I'm wondering whether there are any plans in this budget, or what plans your department has with respect to improving access to the publicly funded blood collection services.
The Honourable Minister of Health.
I'm not sure exactly what the Honourable Member is referring to, but let me just first, in a very general way, say that I and the members of this caucus are very committed to a public system. We are, I think, in terms of our tradition, our values, as the party that the greatest Canadian led in the province of Saskatchewan, Tommy Douglas, when Medicare was introduced, are very aware of that tradition, and we're very proud of that tradition. And not only for ideological reasons, which we sometimes are accused of, but for very practical reasons. And the practical reason is that, in our view, it is important that every possible dollar of healthcare funding that we can wring to provide service and good quality, high quality service to the citizens of our province is really important. And that sometimes the best way to do that is certainly to ensure that it's publicly delivered, that you don't have large multinational corporations with interests in attaining high corporate profits to redistribute to a small number of shareholders, driving the healthcare decisions of our province. And we only have to look at what's occurring today in the United States to see the interests of the for-profit sector there, particularly the insurance industry, which I don't think there's any question are very much involved in the attempt to shape what will occur finally for American citizens that have no health coverage. And this is something that we're very thankful here in this country that we don't have to deal with in that way. And so this is not to say that we don't interface all the time with for-profit industry. There is a lot of for-profit companies operating in the healthcare sector. We buy our supplies from companies. It's a very big business, you know, and we have great partners, but we really like the fact that they have to compete to get contracts, and that gives us an opportunity to try to get the best deal we can. So, but there are certain aspects of our system that we very much want to keep under public control. Thank you.
The honourable member for Dartmouth East.
Thank you very much, Mr. Chair. And I think the minister, I may not have explained it well enough, but certainly got one half of the question, and we probably, I think the minister and I might agree that as things go on in the U.S., I hope they'll use, for all Canada's flaws in the healthcare field, I certainly hope they will come to choose something similar to our model for the U.S. But the issue, particularly as it relates to the Dartmouth General, and the Dartmouth General has been in a situation for a number of years where people are unsure whether it's slowly being abandoned by the health department, but then suddenly they'll get some sort of expansion. The dialysis center was something there a couple of years ago that I attended the opening for, but the fear is that, and blood collection is the latest one, that if you want to go, if you're a citizen of Dartmouth or Eastern Shore or one of the areas that feeds into the Dartmouth General, and you want to go there for blood collection services, your wait time is substantially longer than just going across the bridge and going to the infirmary. There seems to be something fundamentally wrong with that when we want people to be able to access the Dartmouth General, and if we see the Dartmouth General as an important part of the capital health system. So I guess what I would like to know from the minister is what are the plans for the Dartmouth, what is her vision for the future of the Dartmouth General Hospital, and how does her department plan to tackle some of these issues? Today it's blood collection, which is probably a staff, maybe they need more staff, but these are all going to cost money. So what are the plans in that respect? Thank you.
The Honourable Minister of Health.
Thank you very much, Mr. Chair, and I thank the honourable member for the question, and I understand it a little better now. Let me start first by saying to the honourable member that the Premier has sat on the board of the Dartmouth General. I've heard him stand in his place in this assembly more than once and talk about that experience and talk about his commitment not only to the Dartmouth General, but his commitment to the Dartmouth General because he's committed to the people of Dartmouth. And he understands that, you know, the people of your community had a great deal invested in the building of that centre and the ongoing operating of that health facility. So I just want to start by acknowledging that. In terms of the future of the Dartmouth General Hospital. The Dartmouth General is part of the Capital District Health Authority, a very, very large DHA, a critical DHA, not only to the metro area and the people who live in the Capital District Health Authority, but all across the province, people come to our DHA for tertiary care, and from outside the province, from this region. And the Dartmouth General is an extremely important piece of infrastructure in terms of the capacity of this DHA to meet the huge amount of demand that's on it. The Capital District Health Authority has gone through a process of looking at their facility needs right now and into the future. And I think we all recognize the very great challenges that the current fiscal situation places on government to address all of the facility requirements of DHAs around the province. But we also recognize that we have facilities that need more investment. They have great potential to provide maybe more services or different kinds of services than they're providing now. And so in the process of looking to the future, the future needs of the Capital District Health Authority, very much a part of that discussion, and I want to assure the honourable member, it will be a discussion that will occur with the community, not between the government and the Capital District Health Authority, but all facility planning is really a process that needs to include the community, that will be a process of consultation and discussion, and the importance of that particular facility will be very much a critical piece of any ongoing discussion and planning. And it's something that this government recognizes and will be looking forward in the future of seeing what the people of Dartmouth envision for that facility and how we can work toward realizing those aspirations.
The honourable member for Dartmouth East.
Mr. Chair, and thank you, Madam Minister. I look forward to those public consultations. I think the fear, Mr. Chair, in Dartmouth and sort of the areas that services is, as the Minister said, the Capital District Health Authority is enormous. And frankly, one can understand why their focus might be on the cardiology department or one of the transplant departments, and that's very understandable because they're servicing the entire Atlantic provinces in some cases. And the fear is that a smaller hospital, and the Dartmouth General certainly isn't small by standards of some others in the province, but is small by the standards of Capital District Health, that it doesn't get lost in that shuffle, as sometimes seems to be the case. It's very important to the region, and certainly in the case, if we ever had a situation where there was a reason why you couldn't cross the bridges and there was an emergency region-wide, then obviously that would be all anybody on that side of the bridge would be left with as well. I'd like to move on and follow up. One of my first questions sort of alluded to the public-private healthcare debate, and not too far from the Dartmouth General, of course, is the Scotia Surgery Clinic. And I would be interested to know, obviously the Minister's party was very critical of that in opposition, and I'd be interested to know what the plans are for the government in respect to the Scotia Surgery contract.
The Honourable Minister of Health.
Thank you very much. I want to thank the honourable member for the question. Mr. Chair, through you to the member, on the 3rd of June, the former Minister of Health signed an extension to the Scotia Surgery project for another year. So the project has been extended for a year. It also has been expanded from 2 days to 3 days. The Scotia Surgery project is a project that sees minor orthoscopic procedures done in that private facility. And for the people who required those procedures, the response of the patients, because they have been asked what their experience of having procedures done in that facility were, their response was very positive. They had a very positive response. You know, that's a good thing. We want people in our healthcare system to have a positive response. However, having said that, the wait times for orthopedic surgery at the Capital District Health Authority have not been reduced by 1 iota, having this agreement with Scotia Surgery. The orthopedic wait times in the Capital District Health Authority for orthopedic surgery continue to be pretty much what they were prior to the Scotia Surgery project. So, you know, this is the situation that we find. We will, I will, as Minister of Health, and people in our department will continue to work with the Capital District Health Authority to identify what is required to reduce orthopedic wait times. In the area of wait times, we have seen significant improvements in some areas, but the fact that we have seen no improvements in orthopedic waits is something that is of considerable concern to me as minister and to this government, and we would like to find a way to change that. And we have some ideas about how that may occur. We have made some commitments in the campaign, in the election campaign, with respect to pre-opt kinds of programs, and we are planning to fulfill those commitments in the year in which we said we would have fulfilled them in our mandate, which isn't right now. But we're looking at doing something. It's not unusual to find people in our province waiting for close to 2 years to have orthopedic surgery, to have a hip replacement, a knee replacement, and what have you. And it's just not acceptable, really, to have those kinds of waits. So notwithstanding the introduction of Scotia Surgery, and so this contract remains in place for another year, and what I would say to the honourable member is that we will continue to evaluate what the impact is.
The honourable member for Dartmouth East.
I wonder, with the orthopedic times not changing, the wait times not changing, does the minister know whether that's simply a matter of more people coming into the system seeking those, and therefore a wait time that may have otherwise increased is just staying the same, or is that is it roughly the same number of people going in? That would be the first question I would ask related to that. And the second follow-up to that would be, do I understand then from the minister that they in fact have not decided to not renew the Scotia Surgery? I guess that's a double negative, and I'll make that more clear. Have they decided, do I understand that the government has not decided yet whether it will renew the Scotia Surgery or similar contracts at the end of this period?
The Honourable Minister for Health.
Thanks very much, Mr. Chair. To put it as plainly as I can, that decision was taken out of our hands for 1 year on the 3rd of June when the contract was renewed for that period of time. But I would like to say to the honourable member through you, Mr. Chair, that in this budget we have added $1.7 million to fund an increased volume for orthopedics at the Capital District Health Authority. So while Scotia Surgery continues to operate and provide the arthroscopic work, we're not resting on our laurels with respect to CDHA and the work that needs to be done there. And we're in constant conversation with them about developing a plan to reduce the waits.
Thank you. The honourable member for Dartmouth East.
Thank you, Mr. Speaker, or Mr. Chair, and to the Minister. I would appreciate it maybe if at some point, I don't expect you would have this numbers or staff would have this now, but if we could see what sort of numbers were in the system waiting for orthopedic procedures before and what sort of numbers now, because I am interested to know whether the wait time issue whether they've picked up some additional numbers and that's why the wait time is there, or whether in fact there's been no difference. I personally don't actually have a real strong view one way or the other. The second element to that was, of course, the use of the Stadacona Hospital and the military hospitals, which is intriguing to me in that it's a publicly funded hospital, of course, so it's obviously a very different situation in that respect, in the respect of Scotia Surgery, which is private. And so I would be interested to know whether the Minister plans to look at expanding that opportunity or taking advantage of that underutilized operating space and even potentially doctor time.
The Honourable Minister for Health.
Thank you very much. Thank you very much, Mr. Chair. I think if I'm reading the material correctly, there has been an increase in the number of procedures at the Capital District Health Authority by 283 in orthopedics. For certain types, so certain types of orthopedic surgery, we have seen some increase. However, the wait times continue. Now, what that means, I don't know. One of the things that we're very pleased about is the announcement that I was able to make at the Aberdeen Hospital in New Glasgow with respect to the building of the data collection system to really start looking at this issue province-wide. We hope to have this this data collection system in place by July of 2010. Because one of the things that the surgeons and other people will tell you is that it's not absolutely clear when we count people on waiting lists if some people are being counted more than once because they get on more than one list. And Mr. Chair, this was certainly the case before there was a single entry point for long-term care. The wait lists for long-term care facilities 10 years ago in Nova Scotia was horrendous. There were thousands of people waiting for long-term care beds. And the health critic says there are thousands. Well, there are actually probably under 300 now waiting for long-term care. It's still 300 too many. I acknowledge that. We don't want to have people having long waits for to get into a long-term care facility. But the thing about that was that families would go to several facilities. They might be on a wait list at Northwood. They might be on a wait list at St. Vincent's. They might be on a wait list at Glades. And so when you start accumulating the numbers from all of those facilities, the wait lists look very, very high. Every facility managed their own wait list. Well, with surgeries, with orthopedic surgeries, it's somewhat similar. Every surgeon manages their own wait list. And so it is conceivable that there are some people who have seen and been referred to perhaps more than one orthopedic surgeon. So it is possible that the wait lists are higher, that they appear to be higher than the reality. But we don't know that. We don't know that until we're able to construct a single database of some sort, a way to gather information accurately and know that people aren't being duplicated on different lists. And so the The system, the database that we announced on Friday is a kind of significant development in terms of moving us toward better data collection. It's a partnership between the Department of Health and there's a network of surgeons from all over the province that have been participating in the planning of this and in the implementation. And we are we're very happy for this partnership with surgeons. It will make a very big difference in allowing us then, once we know the accurate wait lists, to be able to put resources where they're most needed and where they will be most effective. And the end result will be shorter wait times for people who need surgery. Thank you.
The honourable member for Dartmouth East.
Thank you, Mr. Chair. And just before I yield the floor to my honourable colleague, I'll just say that I hope in hearing that, and that's very good news, but in hearing that, I hope that the government will fairly represent the wait time changes and instead of showing, if it does turn out there's people on multiple lists, Mr. Chair, I hope that the government will, when they show their before and after numbers, that the before numbers will be taking all the duplicates out, and that as the final numbers will be taking all the duplicates out. Otherwise, obviously, it might show quite a success where maybe there's not quite as much of a success as we hope for, although I certainly hope they are successful. With that, Mr. Chair, I will yield the floor to the member for Clayton Park.
Thank you. The honourable member for Halifax Clayton Park.
Thank you very much, and it's my pleasure to continue with the questions here in estimates for health. I was going to start in another spot, but since we're talking about information technology and the announcement that the minister made, I think just within this week, that was made from the New Glasgow area, I think the Pictou Health Authority, I wanted to ask just a couple of questions around that. This, I'm not sure, first of all, where it would appear in the line items. I'm wondering if there is a line item called Information Technology Initiatives, if that's where it is. I had one indicated which has gone down by 2.5 million, so I'm a little bit concerned. Actually, that's on page 14.7, and I must say I'm in the supplementary detail rather than in the main estimates. You may have had difficulty when I was providing the numbers last time. But in the supplementary one, there is a line item called Information Technology Initiatives on page 14.7, and it's down $2.5 million. It's down to 38 million. Actually, when I say it's down 2.5, that's down from the May budget. I should point that out, not down from last year's estimates, which, you know, it's significantly up from last year. But I would like to know if that's it, and if you could explain if that's where we would find this particular initiative, which you've just described as a partnership with the surgeons in the province. I'm assuming the province is definitely paying for it, and the surgeons have lots of good ideas that will hopefully make this a much stronger and a much more effective way of tracking our wait lists. So I'll just wait for an answer on that from the minister.
Thank you. Chair recognizes the Honourable Minister of Health.
Thank you, Mr. Chair. I'm not sure that we have this, I'm not sure that we're looking at what the member is looking at. Supplementary detail. 14. Is it a decrease? Did the member say it was a decrease of 2.358 million? 2. Okay, 2.5. Yeah, we don't think this is a reduction that reflects a reduction in the operating costs of the electronic medical records rapid expansion program. It's not a cut in a program that was being introduced. It's just a reduction in the operating costs associated with that.
Was the estimate too high originally?
Yes. I think this is the problem.
Thank you. The Honourable Member for Halifax Clayton Park.
I wonder if the minister would tell us more about this information technology initiatives line. I hope you've got the right line item as well, because if you look just from year to year, 07-08 to the next year, 08-09, it went from an estimate of 20 million to 26, and this year it's 38. So there's been some significant jumps in this line item. I mentioned in my opening comments that IT has been an area that we've been hearing about here at the legislature for at least the 6 years that I've been a member. And a lot of times those programs end up over budget and behind schedule. And there's a number of them that we can point to. I don't know what's going on here with the great increases from year to year, or if this is completely on track for a number of major initiatives that are rolling out. So my question would be, you know, I've highlighted that item, and I would just like to know what the huge increases are year to year, and if you can explain whether it's one major initiative or is this a combination of initiatives. Thank you.
Thank you. The Honourable Minister of Health.
Thank you, Mr. Chair. And to the honourable member, there are a number of significant increases in various operating areas. The member would know about, I think probably would know about the HASP system, which is the health, it's a health and it's human resources. It's a financial package. In the, it's HASP. Yeah. And it has to do with the, with payroll and benefits area in the DHAs and in the IWK. And to implement this system, this system is a system that the department has been working on implementing and has implemented in a number of areas, and it's estimated that that cost will grow by $3 million this year, for example. Okay. Another program that will result in increased costs of $5,695,000 is an EHR program. It's entering its final year, and it's shifting costs from capital as the project enters implementation and training. And the project will be on budget over the 3 years. But that represents another almost $6 million in that line item. And additionally, there are increased operational costs associated with supporting new IT initiatives, including an EHR program and a surgery program, and that's $3,366,000. I want to say to the honourable member, I understand where she's coming from when she talks about having seen these initiatives of these technological initiatives over a long period of time and wondering what benefit we get from them. It's a very valid question. And there are a couple of things that I'm learning as minister in the early days in the department. You know, our healthcare system is amazingly behind the times when it comes to computerization. Compared to industry, the financial industry, the retail sector, the service sector, insurance, transportation, the airlines. I mean, Mr. Chair, we have a $3.4 billion healthcare system, and we're just starting to get technology really in the last 8 years, 10 years in Nova Scotia, if that. It's shocking. We still have physicians' offices in Nova Scotia with no computers and handwritten records. So we still have long-term care facilities with the only computers might be in the office with the administrator. You know, so this is a problem. We live in a highly computerized, technologically advanced society now, knowledge-based society, but yet our healthcare system, a big enterprise like our healthcare system, has largely significantly lagged behind the introduction and the implementation of technology, and being able to take advantage of the benefits then that technology could provide us. In our big hospitals, for example, being able to restock your supplies and not have people walk up and down the aisles and count boxes and write it down on a clipboard. It's, you know, it's that basic that we really, but the thing about, so that's one thing I've learned. The other thing I want to say to the member is that, and we all know this as MLAs and in our homes, once you have a piece of technology, it becomes obsolete very quickly. It's the nature of the beast to constantly be upgrading, to constantly be looking at what piece you need to add on to do what it is you really want to do. And we've all experienced that probably in our daily work lives, in our offices, or even in our homes. Imagine in the healthcare system, where things are constantly evolving and changing, and new sets of issues emerge, and new questions need to be answered, and new things need to be planned for. So I think this is the challenge when we get into the area of technology. I'm sorry to be so long-winded, but these are things that I've learned that are really fascinating.
Thank you. The honourable member from Halifax, Clayton Park.
I appreciate the minister's comments and letting us know what she's learned as she's taken on this responsibility. I guess you hit the nail on the head when I say, what are the benefits? I do believe we need to be using technology, and there's some direct patient benefits. But, you know, it's kind of amazing to think that we haven't had payroll and employee benefits already computerized somehow. Certainly the rest of the public service are all computerized. We're using SAP, I believe it was, and I would say that was a Cadillac system. That at least my understanding is that it was like a Cadillac system that we ordered up when we went with that program. But that doesn't seem, you know, for healthcare spending, that doesn't seem like a direct benefit to anybody in the certainly patients queued up, or wait times, or long-term bed shortages. Somehow it pales when you're looking at something like payroll and benefits that have now been computerized. That should have been done, as you said, years ago. And I'm not sure why it hasn't, and where there are not, or should we not see some savings somewhere else? If somebody was doing this manually, are there not legions of clerks or something that will now be reassigned somewhere else, or perhaps no longer on the payroll? There has to be some corresponding savings somewhere. So I do wonder about that. And I had written down the question about what are the IT priorities of the government, because I know there are a number of different programs, and you've alluded to them. You talked about an EHR one, I believe, a surgery program. I'd like to know, where are we seeing the priorities that are going to give us the best improvement to the system? The improvement that's going to help patients that are waiting, and people that have health needs that have to be addressed. And, you know, I can think of some that we've heard of and read about, things like, again, computerizing doctors' offices and patient records in hospitals, which aren't all computerized as well. Digital imaging so that we can have immediate access to digital imaging and records that are kept. That would be a priority, I would think, so people don't wait for x-rays or wait for mammogram information to be transferred to their hospitals. You know, I just want to know, where would you say are the key areas where we can improve patient outcomes and improve the system? You know, rather than getting bogged down in a lot of separate projects, I'd like to know that the minister has a priority and an idea about what needs to be done now in terms of introducing information technology and just technology in general to our system. You know, I think that she did a really good job explaining, Mr. Chair, explaining to us that the system has been slow to adopt change and technology, and really, you know, is so far behind that it's going to be a big job to now get us on that footing. But surely there's some best practices in other provinces and places that we can look at that we could say that's the priority we need to do today, you know, or yesterday, the ones that we really need to get going on. And I think that that's very important, that we identify them and that we know that the government is looking for the priorities with the best savings to the system or improvement to patient outcomes.
Thank you. The Honourable the Minister of Health.
Thank you very much, Mr. Chair, and it's a fair question, and I would say without any hesitation that the electronic health record is certainly one of the priorities. It has to be a priority. So many members of our community, their interaction with the healthcare system is in their family doctor's office, and to be able to have the family doctor communicate with specialists, with diagnostic services, to have specialists be able to communicate with each other. This is so critical. I don't think there's any question about that. And so we place a great deal of priority on the electronic health record. Unfortunately, we don't have the luxury of just having a priority and that's what we're going to do and nothing else. We really need to invest in and transform many pieces of the system electronically. As I explained to the member, it's a huge enterprise. It's like a large corporation, and you don't have the luxury of just doing one thing and doing it well. You have to respond to many, many needs, and you have to attempt to do more than one thing and one thing well. So, but the electronic health record is certainly something that's really important and is a priority. I want to also say to the member, and I'm not going to take too much of your time, but I want to say that that part of what this province attempts to take advantage of and will continue to take advantage of is federal dollars. It has been a priority for the federal government in the past through a couple of initiatives, the Canada Health Infoway in particular, to put money, federal dollars, toward information technology initiatives in the provinces. And the extent to which we can take advantage of federal dollars coming to the province is very important. And we actually end up with a number of the projects that we have underway, we end up recovering a fair amount of the costs of those projects through the realization of federal dollars. And so I want to say that to the member as well. We take that into consideration as we look at the menu of initiatives that we really need to do, and we say, okay, how can we get the greatest financial impact to do what needs to be done here? And that's a piece of how we set priorities.
Thank you. The honourable member from Halifax, Clayton.
Still speaking on information technology, the minister has stated a priority item would be the electronic health record, which I certainly know we've talked about and has been touted that actually individuals could carry their record, you know, on basically a credit card. That's what you hear the people speaking about, the vision of being able to have all of your information at hand. And I think that is important as people travel and access health services. But I wanted to ask the minister if she could give us some idea really where that project is at. Are we at the infancy stages of an electronic health record, or are we underway? Are we starting to make headway? You know, I think that's important to know. I also began my questioning by asking what the total budget was for salaries. Roughly speaking, you said 70% of the budget for health is in the salary range. Could you give me some idea, dollar figure, for how much we have identified in the annual budget, this year's budget, for information technology? And again, I recognize they're in different budgets and they're here and there. Makes it hard for a critic to piece it together, and I'm hoping that you would be able to give me, you know, a fairly accurate ballpark figure that takes us to the realm that we're talking about. The one line item I had pointed out is $38 million, but I know that's not the only line item that would be in the budget. So, and that may be a question that requires some piecing together by the financial officers. So if you need to provide it later, that would be fine.
Thank you. The Honourable the Minister of Health.
Thank you very much. And yes, I would say to the honourable member, because IT appears in more than one area, we would have to look at that and do the calculations. But we would be happy to do as best as we can, figure that out and get the information to the honourable member. With respect to the electronic health record, right now, currently, 1,171 healthcare providers are participating in this initiative. This includes 249 family physicians at 83 primary healthcare clinics. 88% of the province's nurse practitioners are also on the provincial EMR, along with 34 hearing and speech clinics and the provincial hepatitis C program, and 72 additional clinics have expressed interest in joining the provincial EMR program. Without a doubt, Mr. Chair, there's a great appetite in the healthcare providers, particularly in the primary care area, to participate in this program. And you know, I remember when the pilot projects were announced. The North End Clinic, which is in my constituency, was one of the primary sites. And I have to tell the member, it has made an enormous difference. This is where I get primary health care, and it's fantastic to go there and to now have an electronic patient record. It has made a great deal of difference for the physicians, for the nurse practitioner, for the nurses, for the nutritionists, and the social worker and the other healthcare providers in that facility. And for patients, you don't see a difference in the kind of healthcare you get. It's seamless. And I had the privilege of being in Yarmouth at the DHA there, and there's a wonderful family doctor. I think her name is Dr. Leahy. It's terrible, I should know this, but it's gone.
Sheila
Yeah,
Leahy.
Sheila Leahy, who works there. And I was taking note of the way that she utilizes technology in her office, not only in terms of keeping records, but as a teaching tool as well. And it's phenomenal. So there's a lot we can do with technology that will transform the way medicine is practiced and healthcare is delivered, and will result, I believe, in many, many improvements in the quality of working life for the healthcare provider and the outcomes for the people who need healthcare.
The honourable member from Halifax, Clayton Park.
I wanted to change gears, but I have one last question on this one that maybe the minister could give us a quick answer to, and that is, given that we have 1,171 providers, you said, that are using it now, is the government doing anything that encourages other practices and other doctors that are getting, that are on our billing number system and so on, to come on board and do this? Is there any incentive or program or encouragement that says, come on guys, you have until this length of time to get on board? Because, we may have all the early adopters already on board. How do we get the others to come and, make it more extensive?
The Honourable the Minister of Health.
Mr. Chair, and I want to thank the honourable member. It's a great question. There are provisions in the master contract that have been negotiated with Doctors Nova Scotia to incent the conversion and the participation in the electronic patient record.
Thank you. The honourable member from Halifax, Clayton Park.
Oh, good. I'm glad to hear that. I don't think where I go has that system in place, so I'll check on that in Clayton Park, because we have a number of, doctors' offices, a number of group practices there. I wanted to just quickly go, I have about 12 minutes left in my hour, and I wanted to ask you something about medication reviews, going over to the pharmaceutical area. I have a bulletin that was from the pharmacists. It's a pharmacist bulletin. It says Pharmacare on it. It actually says it's from the Nova Scotia Department of Community Services. So I'm wondering if that will relate to yours as well. But it said that there was a pilot project for a medication review that would be undertaken by pharmacists, not by doctors. You might, the minister may remember, Mr. Chair, through you, that there was a bill the Liberals had brought forward some time ago asking that there be a senior medication review. It's an idea that is well entrenched in other places, particularly Australia, as I recall, where doctors themselves do a medication review annually for seniors, and it saves a lot of money to their system. They found it to be a tremendously positive thing. Too many seniors are on multiple drugs that they've been on. Perhaps they were assigned or prescribed one drug some years ago, and they stay on that, and then other drugs are entered into the situation. And often they are, one is no longer needed, or they counteract each other, or there's a lot of negative or adverse reactions because of these drugs all being prescribed to the same person. And nobody sat back and looked at what makes sense and whether they should come off that one and be on something different. And so it just becomes a growing problem and a very expensive problem. And seniors, as a result, are often, have, as I say, adverse effects. It may affect their coordination. It may affect their mind, because they can become sort of foggy because of the drugs they're on. It's not good for anyone. So it's a perfectly wonderful idea to review their medication. I was referring, and I don't know if you're aware of this program that said it was a pilot program that was begun in Truro and Glace Bay. It was in March 2008, and pharmacists themselves were going to do a drug review. My understanding of it was that they would choose the customers or the patients that they would review, that they would get their permission first, that there would be a charge then for that review to take place. So first of all, I'm wondering if the minister's aware of it, and if she can tell me how it's going. It's more than a year that it's been in operation now.
Thank you. The Honourable Minister of Health.
Thank you very much, Mr. Chair, and I want to thank the honourable member, and I want to say no, I'm not aware of the pilot project. I don't know if it's a pilot project of our department or if it's a project of the Department of Community Services. But it is something that I, A, will check into, and B, I'm really glad she's brought this to my attention. I know well the phenomenon that she speaks of in terms of seniors being on multiple prescriptions, and sometimes the lack of, for a better word, harmonization between the prescriptions and the difficulties that this can present for seniors. I know that for example, the pilot project at Northwood with the nurse practitioners that have been there, part of the concern was to ensure that attention is paid in a very rigorous way to the adverse effects of prescription medication that many seniors in that facility experience from time to time. I know that this is a question that many gerontologists have, and there's quite a large literature on this. And I know that pharmacists, in terms of their scope of practice, have great capacity that sometimes is not necessarily well utilized in our healthcare system. Which brings me to another initiative that is going on in the department, and this is with respect to models of care. And really looking at having the right healthcare provider providing healthcare services to people, putting the patient first, and the patient at the center of our healthcare system, and saying what are the needs of patients and who is best able to provide care to for those needs based on their expertise. And, I think pharmacists are, in many respects, very capable of doing things that we haven't necessarily had them doing in the system. So I would be interested if the honourable member has more information. Not only that, but with respect to the bill that you made reference to and the information on which it was modeled from Australia to, we say that all ideas that are good ideas are worth examining and looking at and studying, and who knows where it will go. So to the member, provide that information, we'll have a look at it.
No. Okay. The honourable member from Halifax Clayton Park.
Well, thank you very much, Mr. Chair, and I appreciate the minister's comments, because it really is a compelling argument to look at that as the difficulty we have in our current system, where in Australia it is doctors that are doing the seniors medication review. The difficulty we have here is that doctors are not paid for that service. It's not something that they would be doing. Some of the doctors, in fact, say they do it on a fairly regular basis themselves, but it's really hit and miss. And if you make it a standard program that targets seniors in particular, because as we know, the cost of healthcare climbs as you get older, and people tend to be then on a lot more, a myriad of drugs, a lot of different drugs that they have over time sort of begun to be put on. And I'd be happy to give you the information on the actual savings that were documented in Australia by making that a service that doctors would be paid for. This one here, I think the one that I was referring to where pharmacists are doing the review, I think it also, the two names on the bulletin that I have are the Community Services Department, but also the Seniors Pharmacare Program. So I will give you that as well, just so that perhaps you can look into it, and maybe even before estimates are done, we can talk about that again, because it is something we think is very sensible to do, and I think pharmacists may indeed be the right people to do it to some degree. Perhaps they could do it just as effectively as doctors themselves. But we think it's very good, and I'd love to bring the bill in again and discuss the bill with you, because perhaps it's something that could find its way into the practice in Nova Scotia, and we'd be happy to be involved in bringing up good ideas. The other point I wanted to raise, because you actually mentioned geriatrics yourself, and that is in fact that this program that was started as a pilot was not available to people living in nursing homes. It said very clearly it was for people not residing in nursing homes or a home for special care, or it couldn't be somebody who was receiving medicine or medication in compliance packaging. I don't know what that means. But those are the three people or three categories not allowed. And I would suggest that people in nursing homes would be primary candidates for this kind of a review. One reason being a discussion that I had with one of our most renowned geriatric doctors, and that's Dr. Ken Rockwood, who practices here in Halifax, and in fact has attracted a great group of researchers around him. I understand that young researchers come from across North America because of his reputation to work here at Dalhousie and on some of his studies. And in a chance to discuss with him some of this once at one of the health researcher gatherings, he had said that in most nursing homes you'll find many patients are taking cholesterol reducing drugs, and those are the kind of drugs that they give to people my age or the minister's age for long-term benefit, that you keep your cholesterol level low and it helps with your overall heart health and so on. But when you're already elderly, it doesn't have any particular good effect because it is intended for the long term, for years and years of high cholesterol. So it's an example of a drug that we could very easily look at people in the nursing homes and say, it doesn't make sense that they be on it. I don't want to take any drug away that has an immediate or improves the lifestyle of seniors, but if it has no real benefit because it's intended to be for a 10 and 20-year time frame, then really why are we prescribing it? It's just one more drug that they really don't need to take and isn't going to have any real outcome that's positive. So that's a very simple example of something that he just threw out there in conversation and said that there's many other examples like that if we sat down with the experts and looked at drugs. So I go back to the idea of a medication review, and I wondered maybe just in the couple of minutes left the minister might like to respond to that. And I will again go back to the bill that we brought forward and bring to her attention the information that we had that led us to suggest that in the first place. Thank you.
Thank you. The Honourable the Minister of Health.
Thank you very much. And I too am a fan of Dr. Rockwood. And there are a number of very excellent gerontologists, and it's a field that is extraordinarily important. It may be difficult sometimes for people to get access as well. I recognize that, and I've seen people who really required that kind of specialization, someone who really understands many of the features of old age, and some of the specific diseases that are associated, dementia, Alzheimer's, and these diseases that seem to be more prevalent now than they had been. We have a unique, I think, group of researchers in the province in various areas, including Dr. Janice Keefe, who is a specialist on aging out at Mount St. Vincent as well. So I think we have a number of people who we can draw on for a whole array of not only direct services, but really policy ideas that can lead to significantly better health care and, as they like to say, aging in place, so that people have the best quality of life that they can have at any particular time in the stages that we go through throughout our lives. Thank you.
Thank you. The honourable member's time has expired on this round. The chair will now recognize. The chair now recognizes the honourable leader of the Progressive Conservative Party.
Thank you, Mr. Chair, and to the Minister, just a few more minutes and a few more questions. I want to speak a little bit about a program that was introduced in the spring and which was well received. I want a little bit of an update on that, but it's the colorectal cancer screening program. And as the deputy would know, he was there when we launched that, actually in the Bridgewater Hospital. And it was something that the government had given $300,000 to Cancer Care in Nova Scotia in 2007. And it was a plan to implement a population-based screening program, a self-screening program, I might add. And it was to focus directly on colorectal cancer. And the research shows that this particular cancer, when it is detected early, has about 90% chance of being cured. So it's critical that there be early detection and early treatment. And one of the ways that we believe that early detection could occur was with a self-screening program. And it was introduced in 2 district health authorities at that time, early in 2009. And the question that I have for the minister is, can she provide for all of us in the House and for all of Nova Scotians a status report on that particular self-screening initiative in those particular 2 DHAs.
Thank you. The Honourable the Minister of Health.
I'm not entirely sure if this is correct, but it's my perception that the colorectal screening project was implemented as a pilot. It is taking time to evaluate the implementation in the 3 participating DHAs, which are South Shore Health, Scotia, and Cape Breton, to learn where improvements to the program can be made. To date, the response from citizens of these 3 DHAs has been good, but to build capacity in the program, there is a need to incorporate some electronic interfaces with information systems that will allow timely access to information as it moves to other DHAs. This will happen in January 2010, and it is expected that the program will roll out to the next group of DHAs in March or April of 2010. So I think it's important to say, through you, Mr. Chair, to the honourable member and to the people of the province, that the pace of this project has not intentionally slowed, but it is proceeding at a pace that allows a manageable, methodical rollout. Thank you.
Thank you. The Honourable the Leader of the Progressive Conservative Party.
Thank you. Thank you, Madam Minister. And I stand corrected, it's 3, not 2. My question, how is the response being received? How are people who are participating in this particular self-screening assessment, how are they sharing that information so that you at the Department of Health have some knowledge of the participation and the success rate with people using this kit?
Thank you. The Honourable the Minister of Health.
Thank you. The details of this would be with Cancer Care Nova Scotia and with our acute care branch. I don't have that information at my fingertips, but I will undertake to get it and provide it to the member. However, I would indicate again that, in a general way, I've been advised that to date the response rate from the citizens of the 3 DHAs where this program has been rolled out has been good. But what that actually means, I can't tell the member, but I will attempt to find out what that means.
The Honourable the Leader of the Progressive Conservative Party.
Thank you, and that information would be of interest to me and I'm sure to others. When we introduced that as a pilot into the 3 DHAs, the dollar amount that the government gave Cancer Care Nova Scotia was $300,000. I guess my question to the minister is there any information at the department that would tell you whether that was adequate dollars, and if it was not, how much additional cost has there been in those 3 DHAs? That would be my first question. Was $300,000 adequate? And if not, how much would be required?
Thank you. The Honourable the Minister of Health.
Thank you very much, Mr. Chair. Mr. Chair, it's my understanding that in this fiscal year, we anticipate that we will spend $2 million on this program, that the original program had an allocation of $3 million plus 2.7? 2.7. Oh, sorry. 2.7 million plus 300,000, but the 300,000 was not spent. And we anticipate that what we will require to run the program this year is $2 million.
Thank you. The Honourable, the Leader of the Progressive Conservative Party.
Thank you. So just so I'm clear, to run the program in 3 DHAs for 1 year, you're looking at approximately $2 million.
The Honourable, the Minister of Health.
Thank you, Mr. Chair. Yes, I believe that's the case.
Thank you. The Honourable, the Leader of the Progressive Conservative Party.
Thank you. And if I could go back and ask for clarification on something that the minister said, and perhaps she's answered the question already, but if the decision is made at the Department of Health to do a universal application of implementation of this, has that been estimated as to what the cost would be? And would that be the January 2010 date that you mentioned?
Thank you. The Honourable, the Minister of Health.
Yes, I believe that is the case, that it's anticipated that the program will roll out to the next group of DHAs in March or April 2010. Now, I would need to get clarification in the department what that means in terms of the next group of DHAs. I don't know if it means all of the other DHAs or if there's another grouping, of the DHAs that remain. There are six DHAs left, and I'm not really sure. So I will check into that for the member.
Thank you. The Honourable, the Leader of the Progressive Conservative Party.
Thank you to the minister. If that's possible, if you could let us know if that January 2010 is another, as you say, another extension of that, or is it would it be to all of the DHAs? And that information would be helpful. Thank you very much for that. I want to ask another question, if I could, with respect to another new program that has been introduced and has started with implementation, and that's the 811 Telelink program. And as we know, that is one attempt to, I guess, provide some healthcare information, personal healthcare information to individuals on a 24/7 basis. And we know that we have many folks in rural Nova Scotia who don't have access to healthcare, to physicians in their communities, or who may, because of their age or other circumstances, may not be able to take advantage of health care that may be close to home but not in their home. And so the intent of this 811 line was to provide those folks with an opportunity to at least talk to a health care provider, and that health care provider would be able to give them some advice, some direction, and at least help them navigate through and to a more appropriate health care service if that was what was required. And we recognize that one of the ways to do that, of course, was to follow a practice that had been in existence in other parts of the other provinces, and again, allowing individuals to seek that advice and direction. Perhaps without ever having to leave their own home. And we know that some people would find it difficult to make a drive in the middle of winter, 2 seniors on a snowy night in February, not being able to get out. So I believe the intent here is good, and I will be watching, of course, with interest to see what the participation is with that. One of the side, I guess, benefits of that, although it wasn't the purpose for which it was designed, was to see if that would relieve any of the pressure or reduce the number of visits to emergency departments, people who, again, at 2 o'clock in the morning, their doctor's office is not open, they need some advice and care, and perhaps an emergency department trip is not where they should be, but they have no other choice. So this gives them a choice, and I'm very pleased with that. I guess my question to the minister is, do you have a date for full implementation for that particular 811 initiative?
Thank you. The Honourable, the Minister of Health.
Thank you very much, Mr. Chair. And to the honourable member, HealthLink 811 was implemented fully in accordance with the contract in July, the end of July, 29th of July. And since that time, it on average receives about 200 calls a day, which means literally thousands of residents in our province have used this service. And as the honourable member would know, we were the last province pretty much in the country, to go with such a service. And I have to say, I was really delighted to meet the staff who are working in this service. I met a number of the nurses from all parts of Nova Scotia, from Glace Bay, from Timberley, from the Amherst area. I met a woman who was bilingual, who's originally from the province of Quebec, and who had come to Nova Scotia and is a nurse, and was absolutely delighted, Mr. Chair, that she would be able to use her French in assisting Francophone members of our community who would call the line and want to be able to speak with someone in their own language. And that was very, it was just a very heartwarming event the day we launched 811. And the nurses and the managers and other people who will answer that line were so enthusiastic about what it was that they were going to be doing. So the program has been implemented. It's fully operational in most respects, I would say. And certainly we will look at this service over a period of time with a view to what if anything we can add into the service. One of the things that I found particularly interesting, speaking to the representative for McKesson Canada, who are the administrator of this service, is that in some areas, some jurisdictions, this 811 is used as a kind of a mental health counseling and referral line, and to take people who are very distressed and who need to reach out for an empathetic and professional ear. And it has been incorporated into some of the services that are provided. Our service is not geared to do this. It is an information service with respect to your healthcare concerns that are primarily physical in nature. But there is no reason why, if we could see good evidence and information, that it would be useful in the field of mental health as something that we would certainly be able to consider in the future, Mr. Chair.
Thank you. The Honourable Leader of the Progressive Conservative Party.
Thank you, Mr. Chair. And I understand when we were talking about this particular initiative that it did have the potential to expand into other sources of information and other ways in which to help all Nova Scotians deal with their health care issues. I do have a question to the Minister. One of the parts of the design of this particular initiative was that it would allow nurses who were available through the 811 to provide that service from their own home. That would mean, or could mean, that we had this services being provided in many rural communities across the province or in Metro. I guess my question to the Minister is she able to tell us where, what communities would have a nurse who is participating in this 811 telelink initiative?
Thank you. The Honourable Minister of Health.
Thank you very much, and I want to thank the member for the question. I don't have an itemized list of the communities in which each of the nurses are resident, Mr. Chair, but I do know that the nurses were recruited from throughout all of the districts, and that one of the things that the administrator of the 811 program were really pleased about was that they were able to get what they felt to be a very representative distribution of nurses from around the province. And I have to tell you why that was a great comfort to me as Minister of Health. When you introduce a service like this, you do not want all of your nurses from one DHA leaving the DHA and becoming the labor force for a new service, leaving a particular DHA short. But because of the distribution of nurses from across the districts, this has meant that no one DHA was left in a scenario where they had lost, their 2 emergency room nurses, or their 1 ICU nurse, or their senior ICU, or whatever. So the distribution actually was quite excellent in terms of being drawn from the various DHAs and not concentrated in any particular DHA. The other thing I would say to the honourable member, and she would know this, know what the objective was of the operator in terms of recruitment, because concerns were expressed about taking nurses out of the public system and having them work this line. There was a commitment, an idea to look at nurses who had left the regular healthcare system labor force due to occupational injury kinds of situations. Maybe a nurse who had, who had sustained a back injury or other kinds of injuries which can be common to the profession. And so the proprietor did attempt to find nurses who had left the sector, but who still had a lot of skills and a lot of talent and expertise to offer. And so they did follow through on that commitment of attempting to recruit from, an injured nurse. And they had some success, but it was limited. in terms of who they were able to recruit. But my perception, just based on, I didn't meet all of the nurses, obviously, that will be working on the 811 line, but I think I met probably 16 or 18, because they had a very good turnout at the launch. My perception was that a lot of the nurses who have signed up for this program are women who have relatively young children. And a very big consideration for them was that they would be able to spend time with their children. And many of them were looking at leaving nursing for a period of time, particularly if their kids were of elementary school age, to get their kids through the elementary years. And this gave them an opportunity to continue to work as a nurse, use their knowledge, and be in the labor force. And so this actually worked out very well for many of them and for us.
Thank you. Order, please. The time allotted for debate in Committee on Supply has now expired. The Chair will now recognize the Government House Leader.
Thank you, Mr. Chair. I wish you to now rise and report progress.
Is it agreed? Is it agreed?
Considerable progress. The Chair of the Committee of the Whole House on Supply reports. Carried. I'll recognize the Government House Leader.
Thank you, Mr. Speaker. Mr. Speaker, that ends the government's business for today. Tomorrow, after the daily routine and question period, we will once be again going into the Whole House on Supply. I wish you to now rise, the House to now rise to meet at the hour of 2 p.m. tomorrow afternoon.
There has been a motion for adjournment. Is it agreed? Agreed. All those in favor signify by saying aye. Aye. Those against say nay. The motion is carried. We stand adjourned until 2 p.m. tomorrow.